the gene that's associated with Native American ancestry. That's called a false positive, or also called genetic confounding. Well, now with the development of these racially informative or ancestry informative genetic markers, we can at least correct for this difference to level the playing field. And I'll talk about that because my group is spending a lot of time working on that. I get this question a lot. Well, who the hell cares about Hispanics? In fact, one of my most recent R01 reviews came up and said, who cares? It's not applicable to the general U.S. population. Well, the fact of the matter is, it is applicable. Latinos are the largest minority population in the U.S. They're the youngest and fastest growing population in the U.S. And of all children, since I study a child's disease, asthma, they're the largest demographic group. From the perspective of epidemiology, which we are, there's huge opportunities because there's lots of variation in disease prevalence, environmental factors, migration patterns. And if you go a day without a Mexican, you'll realize that this campus would turn brown. You guys wouldn't have your food in the cafeteria. And you probably, if you went to a hotel, wouldn't have your beds made. So from a variety of points, those folks are contributing to the tax base, which is supporting the NIH, and therefore should get a piece of the pie. As an aside, and this is not relevant to this talk, I did mention that most people said they were 100% pure. But according to the most recent census, when you asked Hispanics what they were, most folks didn't know what they were. In fact, the default line is that I'm white. The other half said, I don't know, I'm some other race. And that's a historical thing, and that, we can talk about that at the end. That has implications with the U.S. system of racism versus the Latin American system of racism. In the U.S., we had a one-drop rule where I would have been considered African American, and my experience would have been very different. My grandparents grew up in Mexico, so they had a caste system based on pigment. So you can pass and move up the caste by simply denying your ancestry. But that's a whole nother talk. So recognizing that we need to talk about genetics. There are really two kinds of genetic studies. There's a family-based or a case control study in which one gathers cases, shown here in red, and just compares them to controls. And basically, you look at differences in the allele frequency. So if you see an allele more common in the cases versus the controls, you can say, aha, that gene is associated with the disease that I'm studying. Then there are family-based tests. So this is the approach that we use for all of our studies, where we gather biologic parents and a child that's affected, and we look at the transmission of genes from the parents to the offspring. And not to belabor the point or get too distracted, it's like flipping a coin. If we get heads all the time, it tells us that there's a problem, or that heads may be associated with the disease that we're studying. So we initiated two studies that are going on right now in parallel. One's called GALA, so Genetics of Asthma in Latino Americans. And it was basically to look at the difference in Puerto Ricans versus Mexicans. We gathered about 686 families, mom, dad, and child, from 4 geographic sites: Mexico, New York, Puerto Rico, and San Francisco Bay Area. And we have an ongoing study in African Americans called the GREAT Study. It's gene, environment, risk factors in ethnically diverse asthmatic and therapeutic groups. And by the way, this is what Patrice has her questionnaire piggybacked onto, looking at nutritional aspects in asthma. So recognizing that you guys understand asthma, I'm going to just talk about some of the things that we did. We measured really what asthma is. We also measured drug response, and we measured some other biomarkers. One of them is called IgE. So asthma, I know you guys know what asthma is, but when you're pressed to talk about it, you probably don't really know what it is. Let me just take a second. So asthma is a chronic inflammatory disorder of the airway. Has anyone got asthma here? No? Guess we're lucky. It's characterized by recurrent episodes of wheezing and shortness of breath. And the thing is, it could hit you like that. You could be walking down the field and all of a sudden you can't breathe. From my perspective, if you look at the airways as a long tube, all of a sudden the tube starts squeezing. And when it squeezes, you can't breathe. And the squeezing is called airways obstruction. And this airway obstruction can happen either spontaneously, but it can also resolve spontaneously. So maybe when you got to the other side of the field, it would resolve. But it can also resolve with the use of medication. So we give the most commonly prescribed medication, whether you're at UC Davis or in India, is going to be albuterol. It's a little inhaler. You take it, and it opens up those airways. Well, we can measure this airflow obstruction through a technique called spirometry. And that's where we have kids breathe in and out of a machine, in and out of a machine. And we did this for every kid that was participating in our study. Breathe in, breathe out. On the top, I have exhalation, and on the bottom, I have inspiration. So we had kids do this, and this is a classic flow loop. We gave them a drug after their first spirometry, and then repeated the spirometry. And we can compare the drug responsiveness, how well they respond to the medication by doing a post minus pre. And that's what we call delta FEV1, the percent change in your lung function. How much your lungs open up after the medication. So this is our first result out of GALA. This slide's complex. On the y-axis, I have the drug response. The higher, the better. In orange, I have Puerto Ricans. On the yellow, I have Mexicans. On the left, I have kids under the age of 16. On the right, greater than 16. And what this slide shows is, or doesn't show, is we adjusted here, statistically adjusted, for all potential confounders. Height, gender, medication use, geographic site, everything, you name it, we did it. And still, after all those adjustments, the strongest predictor of how well you responded to a drug, albuterol, was your ethnic background. And that was regardless of your severity of disease. So this slide has tremendous public health, tremendous social and political implications. Because here you have a population that has the highest asthma prevalence in the world, the highest asthma morbidity, and the highest asthma death rates. And yet when a Puerto Rican kid goes for their inhaler, they don't get the same bang for their buck as any other kid. Yet because albuterol, the inhaler, is one of the only drugs that we have for treating acute asthma, we still have kids take it. So it's kind of like lining them up for the death camp, in a sense, knowing a priori that they're not going to get the same effect as any other kid. So that's a travesty. And this underscores the importance of making sure, at least, that when we do clinical and pharmacologic trials, that we include a wide breadth of folks. It's kind of like doing clinical trials in men only, taking that down and saying, well, since women are like men, meaning that they're humans, they should respond the same. You laugh, but we're still seeing papers today that are telling us that men and women behave differently to medications. And, I mean, there's one like last week that came out. Women have different responses to long-term responses to aspirin than men. I mean, this just came out in the New England Journal like a week ago. I mean, it still blows my mind. But anyway, when we added the African Americans in, we saw the same effect. There's no difference between Puerto Ricans and African Americans with respect to response to albuterol, but there was a big difference compared to Mexicans. African American kids that had moderate to severe disease also had low drug response. And what I forgot to mention on that last slide, which I didn't show on here, is that in order to be clinically efficacious, in order for you to meet what we have clinical standards that say you are a good responder or you're not. You have to have greater than a 12% change. And still, what we see is that Puerto Ricans have about half of that. The same was true for the African Americans. So obviously, we're looking for candidate genes that may help to explain this difference. And one of the candidate genes is called the beta-2 receptor. And this gene makes a protein. And this protein sits in our airways. And this protein binds to albuterol. So when you have a genetic variant in the gene, it changes the way the protein